Good afternoon, everybody. I'm Bharat Sachdeva, for those of you who don't know me. And I come back again this year with another controversy. It seems like every time I talk about hypertension, the entire hypertension world has shifted around. So, and I put the same slide I used last year, except for a different heading this year. Again, emphasizing that, medicine is an ever-changing field, and as we get evidence for what to do and how to do, the practice of medicine can evolve, as it has certainly in the case of hypertension. Within the last 80 years, we've gone from a point where it was foolish to try and treat hypertension, and now we are debating what to do with hypertension and how do we define the goal. So I'm going to take you back to this study from early 90s, the Mr. Fit trial. About 38,000 patients were followed on an observational basis. And they looked at these patients only in terms of what their blood pressure is and what happens to these patients in 11 or 12 years. So the average follow-up was about 11 and a half years, and no interventions were done. All they did was they classified the patients based on what their blood pressure is and looked at what their mortality was. And the message was very clear that as the blood pressure, especially above 120 by 80, went up, even small increments in blood pressure brought a higher degree of mortality, as much as 3.5 times more for 150 systolic blood pressure versus 120 systolic blood pressure. And this is where we bring our normal blood pressure, as we call it today, as 120 by 80. They also looked at strokes and deaths related to strokes in the same database, again 40,000 patients, and got the same message that 120 by 80 or even lower than that increases the risk of strokes, and then there is a severe increase as the blood pressure goes up to the highest percentile. So again, suggesting that 120 is about normal and everything more than that is high. And then you combine all of these observational studies, you get about a billion patient worth database, or million patient worth database, sorry, where we have seen that doesn't matter which age you are, as the age goes up, the risk goes up, period. So older we are at a higher risk of heart disease and mortality from heart disease. But within the same age group, so if you were in the 40th, that's me right now, the blood pressure, if I have a 120 blood pressure, I have the least risk, but my risk would be way high if the blood pressure went up to 180 systolic. And then it doesn't matter which age group we look at, for every decade the risk is higher, and the lower blood pressure still decreases the risk. So that's what the observational data tells us, that 120 should be the goal for our patients. But yet our JNC8 and all of the recommendations that have come up have suggested a blood pressure goal that is much higher at about 140 and 150. So the goal blood pressure, or the number that we need to get our patients to, has shifted over time based on what we have known about high blood pressure, and as we get more data from well-controlled, randomized controlled trials, which have shown the benefit of reducing it to a certain level. So All-Had trial was probably the pivotal trial done with 140-90 goal, and showed that in about a 40,000 patient cohort, once you reduce the blood pressure to below 140, you had benefits of several across the board. But to date, we have very few trials which have tried to push the blood pressure down to 120 or below systolic. The only trial, good randomized controlled study, was the ACCORD trial, which only included the diabetic hypertensive patients, and was a negative trial, showed no benefit or minimum benefit for reducing the blood pressure to below 120. And the only statistically significant benefit that came out of a ACCORD trial was that if you reduce the blood pressure to below 120, you would decrease the risk of strokes, some in patients who have diabetic hypertensive disease. So should the goal be lower than 140, and what should be the goal is a question that has been out there. And the SPRINT trial, which is a randomized controlled trial in patients above the age of 50, randomized to a blood pressure goal of below 140, which is a current standard, versus below 120. And is there any benefit? So what I'm going to do today is try to break up this trial for us and see, go through it, and look at some of the strengths of the trial and what the weaknesses are, and see if the study really shows what it intended to show. So it was published last week, was online about a few weeks ago. And the trial was first announced in New York Times on September 11th, where the headlines were that lower blood pressure is better in saving lives, with a 27% reduction in mortality if your blood pressure was lowered to 120 versus 140. So 27% relative risk reduction. And once that came out, it seems like the media frenzy is more on this, and the journals are trying to catch up with all the news in the media. And there are people out here who are kind of wondering, where do we go from here? Because it seems like the goal is always shifting. So let's look at the trial design. So it's a randomized controlled trial, as I said, about 102 centers in the United States, including centers in Puerto Rico. And the study was subdivided into 5 different subregions. So, they were monitoring board that are looking at different aspects of the study. And the primary outcome of the study, as defined by the goal, was cardiovascular, composite of cardiovascular outcomes. And that's pretty much what we get in most of the hypertensive studies, including all-HAT trial. You're looking at the total cardiovascular disease, mortality, myocardial infarction, non-myocardial infarction, acute coronary syndrome, stroke, and heart failure. All of those are directly related and attributable to uncontrolled blood pressures. And we've seen that the mortality goes up as the blood pressure goes above 120 to 150. They also looked at secondary outcomes, which was total mortality and progression of CKD, because that has been another goal that we've tried to look at, lower the blood pressure and see if the rate of fall of GFR can be slowed if you decrease the blood pressure, and is that any different? But the study also had another arm built into it, and for that purpose they had gone out and included elderly patients in their study as well. About a third of the patients included in the trial were above the age of 75, specifically to answer the question, reduction of blood pressure, will it have any effect on dementia and onset of dementia or the degree of dementia? And that arm of the study was going to be followed for about 6 years, just like the regular arm, and required getting periodic MRIs in a subset of those patients and cognitive scoring at different times during the study. The results of the dementia part of the trial are still not out, and they are still closing that part of the study. They published the hypertensive trial because the study was closed early. The study was designed to run for 6 years, but was closed in 3.26 years on recommendation of the Data Safety Board, and I'll talk about that in a minute. So who was included in the study? So patients who are above the age of 50, So the subclass which is going to have the most highly, about 50% of the patients above the age of 50 will have high blood pressure. And the goal was to include about 50% males and females. The study had about 2/3 of the population as males and about 1/3 females. The systolic blood pressure had to be more than 130 at the time of inclusion. It doesn't matter whether you were taking medications or not. So some patients, most of the patients were on medications. In fact, 9 out of 10 patients who were included in the study were already on 2 or more blood pressure medications on an average. But they did not include anybody above 180 because they felt that they would not be able to get them to that goal of 120. And they required that the patient should have a higher cardiovascular disease burden. And they defined that by any of these criteria. Patients who've had any prior cardiovascular disease, if you've had congestive heart failure, if you have if you've had MI in the past, then that would be a cardiovascular disease. If you've had acute coronary syndrome. They did not include prior strokes in that. I'm not really certain, and I really didn't find the answer to that as to why did they not include prior strokes to that. They included chronic kidney disease, and we very well know that chronic kidney disease is an independent risk factor for cardiovascular disease. They excluded patients with polycystic kidney disease, and I think that I agree with that because those patients have a much lower risk of cardiovascular disease compared to other chronic kidney disease patients, especially if they have proteinuria or albuminuria. They included patients with CKD. So this was probably one of the first hypertensive trials in large population that had a significant number of patients with GFR below 60. And that was about 46% of the total population. About half the patients in the trial had CKD. Or if you calculated the 10-year cardiovascular disease risk, that was more than 15%. So if they were a smoker, that would increase their risk. If they have atherosclerotic disease or peripheral arterial disease, that would increase their risk. Or they were more than 75 years of age, which is going to be a high risk for cardiovascular disease to begin with. And about 1/3 of the population was above 75 years of age. So if you look at these inclusion criteria, it kind of looks like my CKD clinic and your medicine clinic, pretty generalizable, minus diabetic patients, because they excluded the diabetic patients. So why did they exclude the diabetic patients from the study? And they did that because a CORD trial was ongoing at that time, and they did not want to include any patients with diabetes, which was supposedly being answered by a CORD, looking at the similar question, does the blood pressure reduction to 120 versus 140 in diabetic patients offer additional benefit? They excluded patients with stroke, patients who had active GN, secondary causes of hypertension. They did not include any patients with proteinuria more than 1 gram. And I think that is one of the major reasons why we can argue that we did not see benefit of, and I'll talk about that a little more, but they did not include patients with significant proteinuria, severe congestive heart failure, or if it was felt that the patient is not going to survive more than 3 years, they did not include those patients. And then poor compliance, severe alcoholics, they don't want to deal with that, so they didn't include any of those. The study identified important subgroups, CKD versus non-CKD, and they wanted to look at those differences. Age above 75 and below, and then African Americans versus Caucasians, and about 1/3 of the population was African American. So a pretty good mix of patients all over. So the second part of the study was, before they started, they went out to look at how many patients do we really need to answer this question whether 120 is going to be better than 140. And they went back to the all-hat trial and looked at the event rate, the primary composite event, how many of those patients who were included in the study had hypertensive-related cardiovascular disease outcomes in the study, which was about 4%. So they did, to be more conservative, they actually halved that event rate to about 2.2% and said, let's include, if we think that the event rate is going to be 2.2%, how many patients do we need? And they plugged it into this complicated formula and came up with about a 9,000 patient population, minimum 9 to 10,000 patients, to have at least an 80% power of finding a difference between the two blood pressure regimens, 120 versus 180. So about 9,250 patients were enrolled, were target for enrollment. I think the final enrollment was about 9,360 patients. And the goal was to include about 4,000 of those, so about 50% of those with a GFR below 60, and then elderly patients were also targeted to be included in the study. So if you look at the baseline patient characteristics, we come up to about a third of the patients above, about a third with CKD, and overall age was about 68 years, which is a little different than all had, and I'm just going to kind of put out these differences as we go along. All had average age was about 64 years, so a little higher age population. And for the patients who were above the age of 75, the average age was almost 80 years. All had did not include any patients above the age of 80, and that was a major difference between the two trials. And all had included patients from 40 to 60 years of age, and their average age was about low 60s. The blood pressures, we could, and that has been one of the criticism of the study, that only about a third of the patients had blood pressure above 145 systolic. At the time of enrollment, only a third of the patients had blood pressures above 145. But then we know that most of these patients were on medication. So that's blood pressure above 145 on 2 or more blood pressure medications. Average, these guys were taking 1.8 medications at the time of enrollment. Antihypertensive medications, 1.8 in both the control and the study arm. So we really don't know what the blood pressures would be if they were not on any antihypertensive medications. There was not a whole lot of albumin. The rate of albumin excretion was fairly minimal, so these patients were not really truly representative of a CKD patient population with proteinuria. These were CKD patients without proteinuria. And that's an important thing to kind of keep in mind. What was the protocol? So they used a mixture of medications, pretty much what we use in our clinic. With the number one medication used was diuretics. The average number of medications used in the intensive arm, 120 arm, was 2.8 medications. And in the standard arm was 1.8, pretty much what they were using at the start of the study. So no difference there. Diuretics were the major difference in the two study groups. About 40% of the patients in standard arms were taking diuretics versus 67% of the patients in the intensive care arm. Again, emphasizing the role of diuretics in being better blood pressure agents, and 55% of these guys were taking chlorthalidone. And chlorthalidone and another ARB were provided by pharmaceutical free of cost, but the pharmaceutical had no role in conducting the study. The study was conducted and sponsored by NHL, so there was no role of the pharmacy companies regulating the study. ACEs were the second. ACEs were also in 76 versus 55, so big difference there. And the calcium channel blockers were also different. So overall, the three most common agents that we use were the most common agents used in this, and then if the blood pressure was still not under control, then they added agents on that list. The protocol included monthly visits for the first 3 months and medication adjustments on every visit, and then visits every 3 months. And then there were 3 blood pressure measurements taken at every visit. And one of the things that had been kind of discussed with Zeal is that they required the patients to sit for at least 5 minutes before the first blood pressure was taken, something that I don't envision happening in our clinics, and then having 3 blood pressure measurements from there on. And then lifestyle modifications was discussed on every clinic visit. They had educators who talked to the patient, but that was not different in the two arms. They used them equally in both arms. And here's what the systolic blood pressure difference came out to be. Within first 3 to 6 months, the two arms were fairly different, and by 1 year, the average blood pressure was about 122 in the intensive care arm, and that effect was sustained throughout the study, with the mean blood pressure in the intensive arm being 121, and in the standard care arm, 139 systolic. The diastolic blood pressures were about 74 in the standard arm and 64 in the intensive care arm. So you have a mean blood pressure of 121 by 64 versus 139 by 74. So what were the results? And the follow-up of the study was designed to be a 5-year study to show that difference in mortality in the two groups and the composite cardiovascular outcomes. But there is that data safety board, which is looking at this data at a pre-specified set times. And on 2 of the assessments which were done before, on August 2015 this year, and the one done in March of 2015 this year, had very clear signal that there is a marked difference in mortality. And because they saw mortality difference, they stopped the study early. So they stopped the study at 3.26 years and did not reach the full 5 years of follow-up that the study was intended to be. And that has come under a lot of criticism because you can argue either way that the study did not complete what it was intended to, but then you cannot ignore the difference in cardiovascular deaths that came in. So if you look at the cause of deaths and how these patients died, so the intensive versus standard cardiovascular death, there is difference. Non-cardiovascular deaths, there's not a whole lot of difference. Kidney disease, accident, suicides. So the major difference was the cardiovascular deaths between the two groups. If you plot the composite endpoint, which was cardiovascular events, there was a 25% lower risk of primary outcomes. If you looked at death from any cause, which was a secondary outcome, there was a 27% lower relative risk at 3.2 years of study follow-up. So if you break it down per year, there is a reduction of your primary composite endpoints that included all of these. And the number needed to treat to reduce one cardiovascular outcome was 61 patients. So if you treated 61 patients for 3 years, you would reduce one cardiovascular outcome. If you treated these patients for 3 years, 90 patients for 3 years, you would reduce one death. How does that really compare with some of the other things that we do? So I went to this website. It's a great tool, the nnt.com. So this website has pretty much data on every clinical intervention that we do. And they are categorized by systems of care. So cardiovascular, you can ask a question. You want to ask a question whether Zosyn saves lives, you can ask that question. So if you ask the question about aspirin preventing acute coronary syndrome, you need to treat about 50 to prevent one acute coronary syndrome. If you ask the question about aspirin preventing death, you need to treat 333 patients to prevent one death. So compare that to 90 patients treated for 3 years to prevent one death. And I think that's really significant. And this thing is I put this in because it's that annoying pop-up that comes in whenever you open a patient's chart now. Does your patient qualify to get CT? That's about 217 patients to save one life, CTs to save one life. So it's quite significant, the findings on the study. And if you break down the outcomes and look at those subgroups that I mentioned earlier, and look at patients who had previous CKD versus no CKD, if you had CKD, the effect was actually not as significant versus if you did not have CKD. So again, trying to point out that in cardiovascular disease from CKD may not be truly only dependent on hypertension. It's a lot of inflammatory that's coming from CKD itself, which does not get better to the same extent as it does in patients who did not have CKD. When you look at the age, both the groups had significant effect, but patients above the age of 75 actually had the most benefit. So now we're perplexed by what JNC8 said, and JNC8 said what it said based on the data that it had. So I'm sure we are out to relook at some of the things that we are doing. Females to males, seems like the males had better effect. African Americans did not have the same degree of benefit as non-African Americans. And patients who had no cardiovascular disease actually had the most benefit. So you break down the study, patients that you think are at lesser risk, patients that we think are doing well or do not need to decrease the blood pressure too low, actually did better with a lower blood pressure. And then, what about the side effects? Because this morning I gave a talk to the sophomore class and I kind of talked about sprint trial. I'm like, why not go down to the 120, which is normal? And the first thing that they raised was, the patients are going to pass out. That you will have a higher risk of side effects. So let's break that down. And there was a difference in side effects in the two arms. So the standard arm, the total serious adverse events was 118 to 220. So nearly doubling of adverse events in the two groups. So if you break them down, what are these adverse events? The most important one that strikes out here is the hypotension. So if you tried to lower the blood pressure low, you became hypotensive occasionally. So similar to patients who had, if you tried to lower the glucose too low, you became hypoglycemic. But the problem there is if you did it too low, the mortality went up. Here, the mortality did not go up, even though you had some hypotensive episodes. And the second biggest one is the acute kidney injury or acute renal failure. So how did they define acute kidney injury? So the study was supposed to check these labs every month, and they did. But they really didn't look at the labs from a monthly basis. They looked at acute kidney injury coded at ER visits and any hospital admissions for these patients. So if any of these patients ended up in a hospital and the doctor coded AKI, they recorded that as a serious event. So we really don't know what was the nature of these AKI episodes, because we know that we're using higher amounts of diuretics in these patients. There was a higher risk of hyponatremia in these patients. Perhaps some of these were what we call the functional AKIs, low GFR drop because of those hypotensive effects that we saw. So if you have more hypotension episodes, you will have more AKI from that as well. What would be really important to see is there any difference in patients developing end-stage renal disease or rate of progression of CKD? So if you look at the CKD patients in this study, there was no difference in the rate of change in GFR. CKD patients had no benefit of blood pressure lowered to 120 versus 140. The rate of GFR drop was the same. But if you had normal kidney function, GFR more than 60, and the average GFR in that group was about 85, in the intensive arm, the GFR dropped more than in the standard arm. So could that be just because of the functional change, that as you drop the blood pressure more, the GFR goes down? We don't know. And the study was not followed up for a long period of time to really answer the question that, are you causing more long-term injury because of lowering the blood pressure to that level? If you look at the serious adverse events, we looked at that. In the specific group of patients which are elderly, so about 1,300 of those, the total number of patients were about 4,000 in each arm. 1,300 were above the age of 75. So is there a higher risk of these adverse events in elderly patients? Are they falling more? If you look at the falls, no difference. Hypotension, total serious adverse events. In fact, in the elderly patients, the difference was not really significant as it was in the younger patients. So less than 75, you had more adverse events with 120 blood pressures. Surprisingly, in elderly patients, the adverse events were no difference. AKI was no difference. But the number of people who had adverse events overall in both the groups were very high, 48% versus 48%. So here's what we know now. So in patients with less than 120 versus 140, these are the side effects that we have to deal with if you wish to lower the blood pressure to that level. But falls are not significantly increased. And surprisingly, orthostatic hypotension was less in patients with the intensive arm versus in the 140 arm. I cannot explain that. So why and what now? Where do we go from here? So I went to the Twitter. The study came out, and the very next day, Nephrology and the ASN has this Nephrology Journal Club, the Twitter club, and there were guys from all over the country, including some international guys, and everybody is excited about this study. There's guys from Mayo, and here's me. And we went back and forth trying to answer some of these questions, and some of these are just as, everybody is just as perplexed at some of those findings. Why would the orthostatic be low? The CKD, everybody agreed that this is really not a CKD trial because you did not have proteinuria patients, those were excluded. And the most benefit that has been shown in the prior studies of lower blood pressure goals in CKD patients was seen predominantly in patients with high proteinuria. So MDRD study, the ASK trial, and the RAIN trial all showed that if you lower the blood pressure below 130, you had a better renoprotective effect than if the blood pressure was above 140. So this trial is not really going to answer that question. But it really brought home the point that in elderly patients where we thought that the blood pressure goal was 150, the goal of 140 does just as well or way better than what we thought it would do in the past. And then everybody had to comment about the number of blood pressure treatments or measurements that were done, and that was interesting to come in with that. So with that background, let's talk about some of the studies that have been done in the past to try and answer this question, but yet no study to date has been done to lower it to 140 except for the RECORD trial. And then there are some studies which have looked at, especially the JTOS trial, which was mentioned by JNC 8 as the reason that there is no benefit for patients 65 and older to lower the blood pressure below 150. Because what JTOS, this is a Japanese study, where they did was they randomized patients to lower the systolic blood pressure from 150 versus 140. And on follow-up on 3 years, they did not find any difference in mortality in the two groups. And so that study is out there. And then there are some other smaller trials that have looked at elderly patient populations and have lowered the blood pressure below to 130 versus 150 and have found no difference. But one of the problems with most of these trials that have been stated is that the power to detect the difference, most of these trials had patients of 1,000. These two trials were about 1,000 each, and this was about 2,000 patients. They did not have the power to detect the difference between the two groups. So they were all underpowered. But what about the ACCORD trial? Because the ACCORD trial had about 4,000 patients. The ACCORD is like a complicated study. I have to read it like 4 times to try and understand it, because it's like a 2x2 designs, and again in different form. And then it has a lipid arm and a blood pressure arm, and then a glycemic arm. So everybody is getting low and high sugar levels with low and high blood pressure levels and a low and high lipid levels. And so if you look at the blood pressure arm on that, that's only about 4,000 patients. And if you calculate the power, it did not have the power to detect the difference between the two blood pressure groups for blood pressure differences. And then there was also a difference in the event rate in the ACCORD trial, which was about 2% per year. And you can argue that the event rate would be lower because the study population the age was lower in that patient population as compared to the SPRINT trial. So that could be a difference that further lowered the power in ACCORD to really find the differences. But since the ACCORD trial, is published, and this is the inclusion criteria. So the age group was about 40 to 75. They have went back and looked at subgroup analysis of a core trial, and this is a busy slide, and I'm going to walk you through that. So let's just concentrate on major cardiovascular disease events. And this is subgroup analysis of the core trial. And this is the blood pressure versus the glycemic. So in blood pressure arm, they randomize these patients to either get standard blood pressure, which is above 140, and standard glycemic control, which is A1C above 7, and standard blood pressure versus low sugar, low blood pressure versus standard glucose, and low blood pressure, low glucose. So if you really focus on the intensive group, standard versus the intensive glucose control or the intensive blood pressure control, they were all towards, there was a benefit, but it did not reach statistical significance. When you look at the stroke, which was really shown to be beneficial, it had a significant benefit, especially if you lowered the blood pressure more than if you lowered the glucose. So there were signs on the core trial, but because of the lack of power to really differentiate the two groups and the sample size being 4,000 patients, perhaps it did not show the changes that we've seen in the SPRINT trial. So what are the questions about SPRINT trial? So early termination is a question because you can really bring in bias, because the moment you see some positive effect and you stop a trial there, you really don't know if this is just a chance effect, because the trial was designed to run for 5 years. But then with the power and the changes that we saw kind of speak to itself, and the study could not have been calculated or carried on from there on because of the wide differences in mortality that were witnessed. I really kind of question, does that make any difference? But because there is a call now that really the clinic blood pressures may only be worth so much, because when patients come into the clinic, blood pressures fluctuate all up and down, and you really need to be looking at the ambulatory blood pressure measurements. But perhaps having a protocol to have them sit down and have a way to measure a more true blood pressure of the patient may work better. And then, should the diabetics be treated differently from the non-diabetics? I think that question is still out there, but if you kind of break down the core and look at some of the benefits that were seen in the core trial, and also factor in the effect that there was a higher mortality in the low glycemic control group in the core trial, and then you put in all of that together, the benefits were seen, although not statistically significant, in the low blood pressure group, even in diabetic patient population. And then we need to worry about the acute side effects in these patients about AKIs and possible risk of falls and risk, which was not seen in the trial. So if you put the two trials together and try and compare, how did the two do? So both in SPRINT and ACCORD, we saw a statistically significant difference in stroke. The non-fatal MIs were, if you look at the SPRINT versus ACCORD, there was difference, but when you combine them, there is not a big difference. You look at the heart failure and you combine them, there is significant difference. When you look at the primary outcome as defined, which is a composite of everything, when you combine the two trials, it seems like the intensive arm is doing better. So here's the dilemma. If you look at the NHANES and see that how are we doing in controlling blood pressures? In 2012, about 80% of the patients who had high blood pressures, hypertension, were aware of it, but only 50% were in control. And this is with a goal of 140. So now we're saying we need to push the goal down to 120. How are we going to get there? So that's really a practical challenge. And this data in 2014 was a little better at about 52%, but we still have a long ways to go to get to decent goals. So I'm going to introduce you to this one other study that was also recently published called the Pathway 2 trial. And they really asked this question that in patients who have resistant hypertension or have blood pressures that are really high and are not getting controlled with the standard 3-drug regimen that we have, that all had suggested that you use either a calcium channel blocker or a diuretic and an ACE. If your blood pressure is still not controlled, what should be the 4th line agent? So a very practical question that we need to ask. So they took 3 groups of medications, spironolactone, alpha blocker, and then a beta blocker, and added that as a 4th agent for bringing the blood pressure to goal. And they found that spironolactone had about a 12-point drop in blood pressure. And it was statistically significantly better than doxazosin or bisoprolol, and way better than placebo. So perhaps there is a sign that aldosterone is playing a major part of those resistant hypertensive patients. And it was well played out. If you look at the renin levels in these patients, if your renin level was low, suggesting the aldo was high, the spironolactone had the most drop in blood pressure. Whereas if your renin was high, suggesting that this is a vasoconstrictive disease, aldosterone did not have that much drop in blood pressure. So again, going back to Dr. Larag's theory of high renin and low renin blood pressure measurements, and it does offer practical utility of checking renin and then titrating your medications based on that. The concern and the risk of hyperkalemia is always there. In this particular trial, the potassium from baseline of 4 went up to about 4.4 in the aldosterone or spironolactone group. An average dose was 50 milligrams, I believe, for blood pressure reduction in this study. So, and the GFR drop is more in patients with spironolactone as compared to other groups. But again, that is a reflection of how well the blood pressure is controlled. So I sent out a survey yesterday to about 30, 40 LSU grads and my co-staff members about, and this is the percentage of fellows and the staff that are responding. Some of these are ex-fellows that have graduated. And this is the question that I asked them. So in light of the SPRINT trial, how confident do you feel to lower the blood pressure down to 120? And this is the question that we have. Where do we go from here? So about 23%, or 1 out of 4 said yes, they are very confident. But 1 out of 3 said no, they're not confident. And then I think the right answer is it depends, because you really have to look at your patient and look at the risk of comorbidities, the risk of side effects, and then decide with a good discussion with the patient as to whether it's worth pushing that blood pressure down to 120 or not. There is benefit. So if your patient can tolerate that low blood pressure, I think it should be achieved. But if you have a risk of side effects, then we need to try and balance that with first causing no harm to the patient and maintaining a close follow-up on those patients. This is a statement from the AHA president who calls that the findings in SPRINT is a vindication of what they had said all along, that in elderly patients, moving the target up is a mistake. And AHA is looking to come up with their new guidelines based off this study and updating their older guidelines. So we may get some new changes coming on our way as to how do we go from here. But it seems like that's the big elephant in the room right now. And I think the evidence is shifted towards a more aggressive control for blood pressure and keeping a close eye on what the adverse effects and the side effects you can have. But that's what we do every day in medicine anyway. Any medication that you give has to be done with a diligence of maintaining benefit and watching for harm. So with that, I'll finish and then I'll take any questions if you have. Yes?
I'll start with a comment and then ask you the question. The inclusion criteria in SPRINT was to have cardiovascular risk. And so patients who had renal failure, GFR between 20 and 59, they automatically had cardiovascular risk. Patients who were older than 75 years of age had cardiovascular risk. And patients who, according to the Framingham evaluation in 10 years, 15%, they. So the question is, there must have been patients between the age of 50 and 75 who did not have a cardiovascular risk.
And they were excluded.
So what percentage of that, when they were screening, what percentage of patients would fall in that category where they had hypertension, defined by them as greater than 120, and they did not have cardiovascular? And the question is, should those people be treated or not? Should this study be applied to everyone above 50, or only the ones who you think have the cardiovascular risk? That's my question.
I think the answer that we have as of today is only limited to patients with a higher cardiovascular risk morbidity. They did have, I do not know exactly how many patients with screen failures. I do not know if that was anywhere in the supplementary data that I went through, as to how many patients had blood pressure alone, but no cardiovascular risk of 15% in 10 years. So yeah, we don't know the answer to that. But I think we know what we know, and we got to use that to the best of what we can. You had a question? No. You had a question?
You could have done that, you would have watered down your events in 3.5 years.
We never know, because one of the things that I was surprised to see was the patients that we felt were at the least risk, no CKD, patients who had no prior cardiovascular disease, but just had a higher risk, 10-year risk, had the most benefit. So maybe the study would have shown us completely opposite, if it included those guys too. Maybe they had benefit. We don't know. I think that's what we don't know. So it's fair to say that a patient who's got no risk at all, doesn't smoke, is healthy, is an athletic guy, maybe his blood pressure could be 130, 140. But if you have that risk, then maybe prudent to look at and talk to them about getting down to that. Any other questions? Thank you guys.